So I'm going to talk to you about telehealth in general, and then we'll talk a little bit about telestroke. This is my definition slide. I find when I talk to people about telehealth, they don't necessarily understand what I'm saying. So just as a brief overview, when we define telehealth as the use of medical information exchanged from one site to another. And as far as from a use case perspective, this could be utilized for diagnosis and treatment, professional consultation, or monitoring and care coordination. The modalities of which is provided, it could be real-time virtual visits, remote patient monitoring, or asynchronous store and forward, so like gathering tests or images and sending it to your physician, and then your physician or your provider is able to see that and respond. The platforms that have evolved in the short time that I've been involved with telehealth, and really our goal is to be as mobile as possible, to get access to people as easily as possible, and moving away more from the hardware-based solutions that we had provided in the past. Or kiosks in maybe retail settings or at health clinics, and Bluetooth-enabled peripheral devices for patients to use at home, or even at quick stand-up clinics like at schools or things like that. So let's get into the fun stuff here. When we look at virtual care and how it's going to grow in the future, this is from SG2 and this is for Indiana. So this is our Indiana evaluation and management visits going from in-person to virtual. And you can see that it's growing in these 4 quadrants of cardiology, stroke, psychiatry, and pediatrics. If you look at virtual care programs across, the nation, but the state here specifically, you'll see that most of our health systems do have work in all these 4 areas. When we look at the system of care at St. Vincent, I break it down into community-based care, acute care, and post-acute care. And I show this to you guys just so you can get an idea that telehealth can really live in any of these settings. And our goal within virtual care is to support that quadruple aim of improving access, addressing care gaps, improving integration, and care management. So again, since we have such a short time, I'm only going to address 3 areas or 3 use cases, 1 in each area. So our first use case is our virtual urgent care. So we just launched this in last spring, and our goal with this is twofold. 1, it's to provide care to patients that are looking for quick ways to see a provider online, maybe when their urgent care is closed, they can't get into their primary care provider, and they don't want to go to the ED. We're trying to avoid misuse of ED. Again, it's not for every type of diagnosis, but if you think about cold and flu, pink eye, rash, things that are easily diagnosed over a virtual visit, so the video platform. Our other goal is to help patients who maybe don't have a primary care provider to enter our healthcare system, so they are introduced to a provider, and then we have a follow-up program where these patients are called if they don't have a primary care provider, and they can set up a visit with one of our primary care providers. So again, improving access and appropriate utilization of levels of care. When we talk about telestroke is actually our longest use case that we've had at St. Vincent. We've been live since 2015, and we're currently in 9 hospitals across the state. And our goal with this is really just to improve care delivery of stroke at outside hospitals that aren't associated with a primary stroke center or don't have neurologists. So what I did is I went on the CDC and I downloaded these maps of our state, and you can see on the first map, this is showing hospitals with neurological services. You can see where the highest concentrations of neurologists are generally where we have the highest populations. And you can see across the state there's a lot of that light blue or greenish blue where there isn't neurological services. The yellow dots are actually our primary and comprehensive stroke centers, and so those are hospitals that have affiliated either with the Joint Commission, HFAP, or the DMV to make sure that the appropriate standards of care are in place and that they are reporting their quality indicators. If you look to the next slide here, you can see that these are our hospitals that have emergency departments, and we have many more emergency departments in our state than we do have neurologists. So the goal is really to provide telestroke services in EDs where there's not large neurological services, and tie them with hospitals who have endovascular treatment or our primary stroke center, so those patients can be cared for at the appropriate level of care as needed. When you're having a stroke, where you live impacts your treatment, and this is specific to IV alteplase administration for ischemic strokes. And while this is a very busy slide, it's hard to really see where Indiana is. You have an idea there with the Lake Michigan just below there. You can see across our state that we still have disparity in treatment. And so the black, red, green, orange, and yellow are where the lower percentage of treatment is. You can see where the blue and green it matches up with where our higher utilization or higher neurological services are. This is a quick data slide that I downloaded from Get With The Guidelines, and just to show what our IV alteplase and endovascular treatment percentage rates are from 2015 to 2017. And while you can see all the way to the left there that our average treatment rate is about 8.6%, these are just from select hospitals that are uploading their information, so they're generally primary stroke centers or a comprehensive stroke center. Nationally, our average treatment rate with IV alteplase is about 3 to 5%. So our goal is to close that gap. So wherever you are, you come into the emergency department, you have improved chances of being treated appropriately. So how does a stroke network work? A patient comes in with stroke-like symptoms. The ED physician sees the patient and makes a determination this is a patient that could be having a stroke. A stroke team is activated through a transfer center or something like that. The neurologist gets online, is able to remote in to see the images, the CT scans, have a face-to-face consultation with the patient and family, make a treatment recommendation, discuss with the ED physician, and then that patient is cared for based upon what those recommendations are. If the patient can stay there, great. They don't all have to come to a higher level of care, but if they need to come to a higher level of care, they can be transferred to a center that can provide endovascular therapy, which increases their window for treatment out to 6 hours after onset, or up to 8 hours after onset, and then returning the patient back to home with a family for rehab. So that's the goal. The other thing I want to mention is that just in July, the state passed some legislation to promote development of these stroke centers of care as systems of care, and that having hospitals become either acute stroke ready, primary stroke center, or comprehensive stroke center, and share that information with the state, and the EMS guidelines will be changed accordingly so that patients will be taken to hospitals that are designated as either acute stroke ready, primary stroke center, or comprehensive. And I think I'm out of time, but just one last quick thing. For post-acute care, we have opportunity as well, and it's again about improving care management, improving access, taking care of patients when they're in a different level of care, and to decrease the chances of readmission. So, thank you.